Okay, great. Sarah Lineberger joined us. Sarah, are you on?
Dana, she might still be on the other call. It wasn't over yet.
Okay, yes. Sorry about that. We had a governor's task for call this morning, and Sarah may still be on the. Dr. Wrighton, have you joined us? Okay, we'll give it a minute. Yes.
Yeah. Can you hear me?
Yes, we can. I have
Okay,
put the
great.
guidance in the chat box that you were going to discuss.
Okay, great. Yes. Good morning, everybody. It's good to be back with you. It's been a little while. And are the beeps just people joining, or is that on my end? Do I need to do something? Maybe that's just people joining.
Yeah, we don't all hear them, Sarah. Sometimes it's weird. Sometimes some people hear them and others don't. I'm not sure what the magic answer is. I'm sorry about that.
Okay, no worries. So yes, CDH did post updated guidance for nursing homes, and that's on the long-term care website. So in addition to what Dana shared in the chat in terms of the link to the guidance, I also just wanted to remind everybody to continue to check the long-term care task force website, because we do continue to post up there sometimes almost daily as new information becomes available. In terms of the guidance itself for nursing homes, we took down just to reiterate, we took down all references to reopening phases. So those no longer apply. Obviously, nursing homes should be following guidance from CMS on both visitation and testing. So this updated VDH guidance document we posted for nursing homes just essentially lays out basic categories of things that are relevant, like training, testing, etc., and then the most relevant documents with links to the guidance documents. So rather than writing everything out, it just sort of simplifies it into a table on the most important things to think about. One thing I want to mention is that we have gotten some questions over the last couple of weeks since this was posted on the PPE section. And so we have a couple of questions that we're looping back with CDC on. We've gotten some questions about gloves in relation to standard precautions and non-COVID patients. And I understand based on the last call I was on that glove supply in terms of ordering has become more limited and more expensive. And so I'm guessing that's driving some of the discussions around glove use. So we're taking that back to potentially update the document. I'm hoping that would this week. We've also been getting questions about linens and laundry and waste. So I think we were trying to add a little bit more language around waste handling. I think some of the questions on some of these basic principles are basically the result of facilities having just a lot of input. We know a lot of different organizations, agencies have been providing guidance throughout this pandemic, potentially have been on site in your facilities, et cetera. So I think some facilities are just trying to clarify across the board what the best practices are. So if you have input or specific questions about the guidance, definitely please feel free out to me. We are going to post an updated version based on a couple of the questions we've gotten. Like I said, specifically around gloves and standard precautions are the questions several times. And then I wanted to touch on several other things while I have you as an audience, and just mention, I'm sure that LeadingAge has shared all the information. Dr. Rossheim put a question in the chat on the supply of N95 respirators. Dr. Rossheim, we talked about that for the first 15 minutes on the provider call we just had. So if you weren't able to join and hear that discussion, I can send the feedback we got, and if other folks have feedback, feel free to put that in the chat or speak up about respirators, and if you've been able to get consistent sizes or consistent brands, and whether that's still impacting fit testing. What I heard on the last call I was on is that many facilities are now able to handle fit testing on site in your facilities, that the supply chain has gotten better in terms of ordering supplies for fit testing, for hoods and solutions. And so it sounds like that piece has gotten better, even though it still requires a lot of logistics and time if you receive different N95 masks. So anyways, if you have feedback on that, feel free to put that in the chat. So I wanted to just take the opportunity to mention a couple other things. So for vaccination, thinking about influenza and COVID, and planning for a COVID vaccine. For influenza, I would really appreciate hearing if there are any barriers to vaccinating both residents and staff this year for influenza. That's a message that we've been pushing and have pushed in other years too, but obviously we're in a unique situation right now, and feel like, influenza vaccination is a really important precaution to take. We always see a high percentage of uptake for flu vaccination in long-term care staff. So, if you all have with any creative ways to message that to staff, the importance, etc., that would be helpful. We also, and I'm going to touch on Thanksgiving here in a minute, we also are just encouraging facilities to encourage family members who will be visiting with loved ones over the coming holidays, that family members are also getting flu vaccination. That's always recommended, that if you are going to be around high risk individuals, that you help protect those high risk individuals by getting your own flu shot. And so that's another message that facilities could carry forward to family members if you haven't already. So definitely open to any feedback on influenza vaccination and continue to push that as an important precaution to take right now. In terms of planning for COVID vaccination, a lot of information has gone out on the federal pharmacy partnerships. There was VDH held another sort of question and answer session Monday morning on that. We did get a list, I think last night, on the facilities who have signed up for that pharmacy partnership so far, and it is a pretty large number in Virginia. And Dana and others, I believe the intention this morning is to share that list back with the association so that you can see which facilities have signed up and which haven't. The deadline, we did clarify with CDC, the deadline for signing up for the pharmacy partnership for COVID vaccination is this Friday, November 6th. And whether you're a nursing home or assisted living facility, there are different ways to sign up. And we have previously answered a lot of questions around that. information on the website, but I would be happy to take questions if there are questions on this call, and talk through that more. I guess I could stop there. I have a few other topics, but Dana, I don't know if it'd be helpful if I stop there just to see if there are any questions around the vaccination program or flu vaccination.
I'm not sure what happened to Dana, Sarah, but since we haven't had any questions come into the chat, I'd say keep on going.
Okay, great. Thanks.
Thanks.
So LeadingAge does strongly encourage facilities to sign up for that federal pharmacy partnership for vaccinating residents once a COVID vaccine becomes available, because it's sort of a turnkey service where one of the larger pharmacy chains would order the vaccine, store the vaccine, come on site to your facility, administer vaccine, and then report vaccine administration. So like I said, many nursing homes and assisted living facilities in Virginia have already signed up for that, and sign up ends on Friday. And Allison mentioned that adult day cares are signing up as well and are appreciative to be considered in this program. Yes, if you're another facility type, please feel free to go ahead and sign up. CDC is aware that there are many other types of facilities that would benefit from this federal pharmacy partnership. I think whether it's extended to adult day care, group homes, et cetera, will be a decision made at pretty high levels within the federal government, and will probably depend on a lot of factors like what vaccine is available, how much vaccine is available, et cetera. You know, depending on how the federal pharmacy partnership shakes out for long-term care, then we would, you know, take the next level of planning back to the state in terms of figuring out how to work with local health departments and others to cover other settings. Dana asked, how should communities handle registration when they have multiple levels of care? Dana, I think this has been addressed on some of the vaccine calls that we've had. Do you recall the answer?
I thought they were still
Dana.
registering, Sarah. This is Melissa. I thought they were still registering, and then once the vaccines are available, there will be decisions made on whether or not all levels of care will get it, but that they should still register all levels through REDCap. Does that sound right?
Yeah, so the nursing home, if you're a multi-care level facility and you have a nursing home, the nursing home needs to register through NHSN, but any other levels of care can register through REDCap. What I was trying to remember, I think that you should register each level separately through REDCap, and that's what I was trying to remember, Dana. I think that's what we said. If you have different levels of care, then you should register. I think it gets a little tricky because Mike Magner seems to think that maybe if you have multiple levels of care at your facility, the federal pharmacy partnership would just go ahead and vaccinate everybody if you're all on one site at one location. But if you have different physical locations, then you definitely need to register those separately in REDCap. And the nursing, any facility with a nursing home definitely needs to register that through NHSN. Does that help? I hope I didn't just confuse anyone more.
No, that was good. Thanks, Sarah.
Okay. Okay, and then I want to mention a couple other things and then talk about Thanksgiving. So we have started getting questions on reporting point of care results from nursing homes. Obviously, right now, all long-term care facilities should be reporting any antigen results or other point-of-care results through the VDH portal. That's been live for several weeks, and we are getting that data that's going into our overall surveillance system. And so thank you for reporting into that VDH portal. A lot of long-term care facilities are reporting those antigen results. And if you are not and need help with that, please let us know. I think it's pretty straightforward, and there's a way with that portal to report aggregate negative results in aggregate rather than by patient. But we're getting questions now because NHSN has said that they will also be moving to level 1 reporting in NHSN for nursing homes, and that means patient level reporting and reporting patient level results from point of care testing. And so we are getting questions. We've had some internal conversations at VDH. We certainly do not want nursing homes to have to duplicate reporting, but nothing has changed right now. You should still be using the VDH portal because it's still unclear when CMS will require the NHSN reporting. We did, and I'll copy it into the chat. We did post a note on the long-term care task force website about this, and basically nursing homes are supposed to be working with CDC to upgrade their SIMS access to level, maybe I got it wrong, level 1 or level 3, whichever one includes patient level results. I think it's level 3, sorry. And then, once CMS has said that reporting is required into NHSN, we will work with nursing homes to figure out whether you should be reporting to one or the other, and we'll be sharing data on the back end. But in the meantime, you should keep reporting to the VDH portal because CMS and NHSN have not required to go live with reporting those point of care results in NHSN. So that's for nursing homes. Hopefully that makes sense. Keep reporting to VDH, but we definitely do not want facilities to have to duplicate reporting. So we're working on that, and essentially right now waiting on more information from CMS. Does that make sense, Dana? Okay, hopefully that makes sense. And then related to NHSN reporting, the vast majority of nursing homes have conferred rights to VDH so that we can see the information you put into NHSN. That's really important because we are using the data that you enter into NHSN weekly to look at PPE needs, cases being reported, staffing needs, et cetera, and also looking at any information in terms of COVID vaccination planning. So as of last week, there were still about 76 nursing homes in Virginia who have not conferred rights to VDH. That's a one-time process. The NHSN administrator has to go in and basically check a box and agree to share data with VDH. This is something we've been doing with hospitals for a long time. We can see all the hospital data in NHSN. And so this is required per our regulations, so encourage you to do that sooner rather than later. We're working with the associations to reach out individually to nursing homes who haven't shared data yet with NHSN, with VDH via NHSN. Okay, and then I wanted to just briefly talk about Thanksgiving. I know that you all talked about that last week on your LeadingAge call, and a couple of my team members were on and listened in, and that was really helpful. VDH is putting together a couple one-page documents about Thanksgiving planning that we hope will be helpful. One for residents to basically encourage residents to take advantage of facilities offering Thanksgiving dinner, visitation, etc., inside the facility to have family members come in. That does seem like a lower risk option compared to residents leaving, but it sort of lays out steps 1, 2, and 3 if a resident's leaving, what they should think about before leaving, what they should do when they're off-site from the facility, and then what to do when they come back. And I know some facilities are talking about quarantining or testing residents or both once they come back to a facility. And then we also heard this morning from Kim Beasley at OLC, and I don't know if Kim's on the line, but that we are expecting CMS to come out with more information around visitation related to Thanksgiving and other holidays, but we do not have a timeline on that. From the LeadingAge perspective, we're going to try to put something out this week. We know facilities are already planning around Thanksgiving. It's only 3 weeks away, which is hard to believe. But we also, in addition to residents, see this as an opportunity to hopefully underline some of those basic infection control measures with staff as well. We just talked about this on another call, but basically, you know, we're seeing across healthcare in general, not just long-term care facilities, but also hospitals and other settings. You know, staff members are tired of COVID, getting complacent in terms of some of the PPE use and social distancing. We've seen in hospitals recently what we've seen in long-term care facilities months ago, and you know, including staff not social distancing in break rooms or staff not social distancing when they're not at work. And we are concerned about increases in community transmission. Obviously, that's happening nationwide, but also in some regions of Virginia, particularly Southwest region, which we think is being impacted by transmission in neighboring Tennessee. Because there are a lot of transfers in Southwest Virginia with nursing homes on the Virginia side and hospitals on the Tennessee side. Like, we see that all the time. So we've seen in this pandemic that any transmission in the community ultimately contributes to transmission in long-term care facilities. So even though it's hard and difficult and we understand the complacency and the fatigue, we're really just trying to reiterate basic infection control measures with staff and anyone else as much as we can. And would appreciate any input on creative ways you figured out how to do that. With infection control programs, it is important to provide regular feedback and regular training. You know, if you see a staff member not wearing the appropriate PPE, the best thing to do is just correct it at that moment. You know, you can do that in a non-punitive way. Reminders are always good. Auditing and giving feedback is helpful. And those are things we think about with infection control all the time, whether we're in a pandemic or not. So I will stop there and happy to take any questions.
Sarah, this is Melissa. I don't see any questions. I just see that Dana posted. OLC said that the CMS guidance may require that residents that have an extended leave from the community for the nursing home to implement transmission-based precaution when they return. And it looks like Rebecca is submitting a question now. Nope, I'm wrong. Did you have any other? Oh, Sarah, apparently somebody sent you a message privately. Did you get a chance to look at that?
I haven't, but I can do that right now.
And then another question that came in, how should we go about requesting level 3 access through SAMS?
That's all through CDC. I can find a link probably. I don't know, Dana, if you have anything off the top of your head, but it would be CDC is who does the SAMS access. So I'm guessing you have to reach back out to CDC or the NHSN help desk for that. Yeah, Karen is saying you have to email NHSN. I can put something in the chat about that. So Julia is also saying she emailed NHSN and used the subject enhanced data security, which they advised us to do. Yeah. So I'm guessing, did you all just email NHSN at cdc.gov? That's their help desk. Okay, Julia's saying yes. I will, if we're moving on, I'll go to the private messages too and try to answer those as well.
Okay. And then, yeah, a couple more just came in. Do you see those?
Yeah, Karen's mentioning that you have to get a form notarized. That's correct. We have to do that on the public health side as well for anyone to access NHSN. So that's where this level of access gets a little more challenging for registration, and I think is why they initially had nursing homes register for a lower level of confidentiality. But yes, the user who's going to have that access to enter patient level data into NHSN does have to get a form notarized to basically verify that they are who they are, and then that gets uploaded and put into the SAM system. So it's a process that takes a little bit longer than probably well, I know the process for getting all nursing homes into NHSN took a while too, since everyone was trying to do it at the same time. But I would encourage you to go ahead and try to start that process of getting the higher level access, because it will take at least a few days to do that. Yeah, so yeah, thanks Karen and Julia for that input. And then Ryan's asking about point of care testing in NHSN and whether they would input information on testing visitors. That's a really good question, Ryan. I don't think that we've thought through that. If there's not an option in NHSN, then I'm guessing that VDH would want that data for our case counting purposes. So let me take that question back to our surveillance team. Like I said, we've had a couple internal discussions on using the NHSN system versus the VDH system and trying to connect those two. But let me take that question back. Thanks for asking that.
Thanks, Sarah. Is there anything that you were messaged privately that it would be good for the whole group to hear?
There's a question about which flu vaccine is acceptable for long-term care residents. And I know there is the higher dose vaccine available for the older population. And I think that's generally what is recommended. However, what I'm not sure about is whether it makes sense to wait for that, or how long it makes sense to wait for that. And I don't know, I'm not the vaccine expert. I'm not sure how available that higher dose vaccine has been this year. So I will loop back with our vaccine team at VDH on that. Agree that's typically recommended for the older population, but I also wouldn't want somebody to just not get a flu vaccine at all, if that is not going to be readily available. So I will take that question back. And on these questions, Dana and Melissa, I can just follow up with you once we have answers, and then you can
Perfect.
share information back.
That's a great plan. Thank you.
So there was that question, and then I also got a question on sharing information on how to report into the LeadingAge portal, and I can add that to the chat box.
Excellent. Sarah, thank you. Is there anything else before we transition?
No, I think that's plenty for right now. Thank you.
It's been quite a morning, and it's 11:30. So
Exactly.
thanks, Sarah. Thanks so much for always being here and supporting us. We really appreciate all you do. Dr. Roshheim, are you on?
Yes, I am. Can you hear me?
Yes. Thank you so much for being here. The platform is yours.
Okay. I do have some slides, but I can't seem to upload them.
We are looking at your first slide right now that has COVID-19 testing update. Virginia's health is in your hands.
Oh, okay. All right. Then I have to. Okay, so I'll just let people know when I'm moving on to the next slide. Okay. Well, I wanted to provide obviously a testing update, so I'll just go ahead and get started. So moving on to the next slide, slide 2. I always like to present an overview of basically where we are with the COVID-19 pandemic. So this is data from CDC as of November the 2nd. And then you see the maps on the right-hand side. So total reported cases are 9,182,628. And you can see that that was up from about 77,000 cases from the previous day. Total reported deaths, 230,383, up 451 from the previous day. If you look at the maps, at the top map of the U.S., the darker blue indicates more cases. So you can see that really the Midwest and upper Midwest is getting more cases now. These maps show basically over the last week. The bottom map reflects death data, and you can see that, basically, pretty, wide, spread out through the U.S. with some increased deaths in the upper Midwest recently. If I go to the next slide, slide 3, looking at Virginia data as of November 2nd, we see total number of cases of 183,418. Total number of hospitalizations. Hello? Can you all hear me?
Yes, we can hear you. I don't know what that was. Just remember everybody to mute your line if you're not speaking. Thank you.
So total hospitalizations, and all this data is cumulative, 12,674. Total deaths, 3,658. In the map, on the top right is the number of cases, and this is case count data. The darker blue represents more cases. And you can see that these are, what you see as cases are all over the state. When you look, the bottom map shows deaths. What you see is deaths throughout the state, but you tend to see a little bit more concentration in Northern Virginia, Central Virginia, and Eastern Virginia, where, bigger population centers are. Moving to the next slide, slide 4, COVID-19 diagnostic testing. So typically, as everybody probably knows, nucleic acid amplification testing using PCR has been the preferred method for diagnostic testing for COVID-19. This test looks for genetic material. In particular, what it looks for is RNA. It is highly sensitive, highly specific, which means that there are there should be few false positives and false negatives. But there is a downside, which is that PCR testing is expensive, and depending upon the demand for PCR testing, labs can get quite backlogged, and we've seen that before, where if you have a crush of demand, that your lab providers may take 3, 4, 5, 7+ days, and that's not really very helpful to the patient because you really want that information promptly. So another type of testing was developed, which is antigen testing. These antigen tests look for proteins that are on the surface, typically, of the SARS-CoV-2 virus. And this is another viral diagnostic test. Antigen tests are indicated, and they have their emergency use authorization from FDA is in symptomatic patients. So those people who have symptoms that are consistent with COVID-19, the antigen tests do need to be run within a certain time of when the symptoms began. That varies by test. And they do have some advantages. One is that they are less expensive, sometimes considerably less expensive. And the second thing is that, right now there are 7 antigen tests available, and 6 of those are available in a rapid point-of-care form, which means that they can be done right at the point of care, and results can be obtained in basically about 10 to 15 minutes. And that really is a huge help, and that's a far different thing than doing PCR testing, where you're going to need to, most of the time, send it to a lab. One of the disadvantages of antigen tests is that they are not as sensitive as the molecular tests. And so one thing that can be run into is you get more false negative antigen tests, and these may need to be confirmed with PCR testing. So in essence, the test accuracy not quite as good, which means you may need to do a second test, a better test, to confirm the first test. The other thing is that we've also had reports of false positive antigen tests. So both have been reported. And that's where it leads to the next bullet, which is that there really is no perfect lab test to detect SARS-CoV-2. CDC, does consider and does state it in print that, PCR is the gold standard of testing, at least at this point in time. And I put a link for CDC guidance for rapid antigen testing at the bottom. So going to the next slide, I thought it would be helpful to talk about the sources and types of COVID-19 antigen tests that are out there, because this can get a little confusing. So the U.S. Department of Health and Human Services, which is HHS, one of the things that they did a while back is they distributed the Becton Dickinson, or BD, Veritor, which is the brand name of BD's device, and the Quidel, which is the manufacturer. The Sophia 2 is, again, the brand name of the device. They distributed these rapid antigen testing platforms to nursing homes all across the U.S. And these are rapid point-of-care antigen testing platforms. And so in Virginia, just about every nursing home received the BD Veritor analyzer and test devices, and only a very small number of places received the Quidel Sophia 2 device. So that was one thing that HHS did to basically provide a here's a point of care device, here are the test devices themselves, and this is what you swab people and then go ahead and test them right there. And so that was one thing. Then a second thing was that, as you may have heard, is that the feds purchased $150 million of the Abbott Binax Now COVID-19 antigen cards. This is another rapid point of care antigen test device. And this one is unique because it does not require a machine. It does not require a testing device. The card is the testing device. So these were distributed nationwide, and some cards went automatically to assisted living facilities that had existing CLIA certificates of waiver. The remainder of the cards are basically being distributed now to the states, and the governors of the states get to decide how these tests are used. So as an example, in Virginia, some of our assisted living facilities did get cards directly from HHS, and also some cards went to other places, such as historically Black colleges and universities and other locations. And what we're receiving now in Virginia is that remainder of the shipment. Virginia is anticipated to receive 2.6 million cards by the end of 2020, and they're coming in basically about weekly shipments. It's roughly about 100,000-ish a week, and LeadingAge and partners are currently deciding, and in the testing, we've had many calls about, with different stakeholder groups about getting, who wants to get, cards. And so, we are definitely trying to honor as many of those requests as we can. So that was sort of the first part that HHS did. And then the Commonwealth has grant funding, and y'all may remember this from a while back, where the governor, can y'all hear me okay?
Yep, you're coming through loud and clear.
Okay, great. So the governor said that, Virginia was working with other states to purchase up to 500,000 antigen tests, and that is very much alive and well. And so about 2 weeks, and so, we participate in weekly calls with the multi-state collaborative. And about 2 weeks ago, Virginia did purchase 7 BD Veritor analyzers and about 235,000 tests. So these will be coming in, excuse me, pretty shortly. And I think some of them may have come in already. I'm not totally sure about that because I don't handle that aspect. So moving on to, so these are the sources of antigen tests that are available at this time, and all of these have been made available at no cost. That's where we stand right now. Moving to the next slide about antigen testing. As we said, these tests are meant for people with symptoms. Now, however, having said that, one of the things that FDA did say, because now that we've got all these antigen tests available, is according to FDA, if molecular testing, so if PCR testing is not available, or the turnaround time to get PCR results is excessive, so more than 48 hours, then antigen testing can be used to test asymptomatic people for COVID-19. that has led to a lot of discussion about, the utility of antigen tests, because this is not exactly what they were designed for, and that is considered an off-label use of antigen tests, because if you read the package insert for the test, it will tell you that it is meant for symptomatic people. Now that's okay. The medical provider can use the test off-label if they want. That's fine, and that's done in medicine all the time. The problem is that we have limited data regarding the accuracy of using antigen tests off-label, and that's where people get, there's been some concern raised. We're certainly eagerly awaiting more data about how antigen tests perform, particularly in this kind of situation. If antigen tests are used in this way, there definitely will be some confirmatory PCR testing that will be needed, and you'll see that in a slide or two. And this does have potential implications for nursing homes, since nursing homes are required by CMS to test their staff based on the percent positive PCR tests in the locality where the nursing home is located. So what I mean by that is that, if you're a nursing home in locality X and you are testing your staff, twice a week with antigen testing, you're probably going to need to follow up some of those antigen tests, the positives, and also perhaps the negatives with PCR testing. And we've talked about the fact that just about every nursing home in Virginia has the BD Veritor. So moving on to the next slide, slide 7, COVID-19 rapid antigen point of care testing. There are some important things to know about point of care testing, regardless of where it's done, whether that's a nursing home, assisted living facility, a doctor's office, urgent care center. So all of these antigen tests are prescription only. So they do require a medical provider to order the test. All of these rapid point of care tests are CLIA waived. Okay, so the facility that is doing it needs to have either a CLIA certificate of accreditation, so for instance, if a place were to have a lab already, they might have a CLIA certificate of accreditation to do their own in-house microscopy, like looking at slides under a microscope. If you have that, that's great. You don't need any other CLIA certificate. Or if you don't have any kind of CLIA certificate, you can get a certificate of waiver, which means that you can only do CLIA waived tests. And these rapid point of care antigen tests are all CLIA waived. The facility does need to have someone designated as the lab director. And what will happen is when you get your CLIA certificate, that lab director, that person's name will be on that certificate. The people performing the rapid antigen test, they do need to be trained to do so, and they need to be under the supervision of the lab director. And I put a helpful hint, which is to reach out to the manufacturer of the test to see if they have a training program. For example, Abbott has a trainer in Virginia. We have called her a lot. She provides trainings on how to use the Abbott Binax Now cards. I can provide anybody that wants to get training with her information. Abbott also has videos that you can watch. The point is that what you want to demonstrate is you want to demonstrate, yes, if I'm the one performing the test, I took the training. I can show, if the company offers a certificate of training, definitely get that. That is a good thing to have, because what it does is it shows evidence of training. You also have to demonstrate competence that the person can do the test appropriately. As we've already said, and I know you all know, that all test results, both positive and negative, must be reported to VDH within 24 hours. And obviously, there needs to be follow-up for patients and or staff who are having tests done, particularly for those who have positive test results. Remember that these are prescription items. So, in general, the person who writes the prescription owns the test result. And so, therefore, that person would be the one to, communicate with the patients. There are some exceptions to that. I won't get into that now, but just to know that results do need to be communicated. This next slide is a screenshot from the VDH interim COVID-19 antigen testing recommendations. This was a document that we released on October 28th. And I won't go through the whole thing. Basically, what I will note is that these are our recommendations. These are not mandates. These are not requirements. So these are our recommendations about how to handle certain different situations. So if you've got a symptomatic patient, with a positive test, negative test, you've got an asymptomatic person who is a known close contact to a COVID case, and then in the third column, you've got an asymptomatic person who is not a known contact to a COVID case. And you can see, what I will tell you in brief is that if you've got a clinical situation where the clinical situation does not match the antigen test result. So for example, let's look at the first column. You've got a symptomatic person who has a negative antigen test result. That's one where the clinical and the test differ, and that's one where you're going to want to get a confirmatory PCR test. And the same goes if you've got a person who is asymptomatic, not a close contact, and the antigen test is positive. So that's another reason to get a confirmatory PCR, because is this antigen positive a real positive, or is it a false positive? So moving on to the next slide, home-based specimen collection. I did want to bring your attention to the fact that there are a bunch of companies that do offer home-based test kits where specimens are collected. The actual test processing is not done at home, but the collection is. So these kits differ in terms of how they operate. Some of the kits are the patient calls up and orders the kit and answers, medical questions. Sometimes the medical provider orders the kit and it's mailed to the patient's home. The bottom line of this is that this is a way that patients who are predominantly at home can be tested for COVID-19. This is not really meant for an acute situation because there is obviously turnaround time. The specimen's collected. It's got to be FedEx back to, or UPS back to the lab. But these are out there. Now, if you go to the next slide, what I've done is I've given you the link on the previous slide to FDA's website that covers these tests. And by the way, these are all PCR tests, so none of these are antigen. So what I've done is I've given you a screenshot of this list, which is about 150, rows long. And so if you look at the top one, the way that you'll know that it's a home collection is you look at basically what FDA has in each of the rows. So if you look at the PrivaPath Diagnostics, you'll see in that column it says, TMA, chemiluminescent, home collection. And you'll see some reference to home collection to indicate that is something that can be collected at home. And then The last thing that I wanted to mention is that point prevalence surveys are being done at assisted living, and if there are some assisted livings that multiple attempts have been made to reach them to try to do a point prevalence survey, this is something that LeadingAge strongly recommends. And some assisted livings, I guess, have not been able to be reached. So just to let everybody know that as of November 7, no further attempts will be made to contact these assisted living facilities. So if an assisted living does want to have a point prevalence, has not had one, and wants to have a point prevalence survey, which is definitely a good idea from overall, please reach out to your local health department now, and please let them know that you would like to have a point prevalence survey. Those are all the slides that I have. If you have questions, I'm happy to take them now, or you can email me at the email address. Thank you.
Thank you so much, Doctor. One question did come in, and the question is, if a staff member tests positive with Quidel and then negative PCR, and the staff was asymptomatic, this person is not considered a positive case regarding outbreak?
Okay, let me say that one more time.
Yeah, that's complicated. So if a staff member tests positive with Quidel and then negative through a PCR, and the staff was asymptomatic, that person is not considered a positive case regarding outbreak?
Okay, we need an additional piece of information, and that is we need to know whether this staff member is a known close contact or not to a COVID-19 case.
Okay. And if they are?
If you have someone who is antigen positive with the Quidel and is a known contact, we are going to consider that person a case. So that person is going to be considered to have COVID-19 because of the fact that they've got positive antigen tests and they are a known contact.
But if they have had no known contact, you would not consider them.
If they have no known contact, and I'm going to go back to the slide because if they have no known contact, then they're going to fall into the category of needing quarantine. I'm sorry. You said no known contact?
Yes.
Okay. If they have no known contact, they have a positive antigen test.
Yep.
And then and then we would recommend a confirmation with PCR. If the PCR is negative, then we're going to go with the PCR test. So they're going to be it's going to be considered a false positive. That's again with no known close contact, and again asymptomatic person.
And then Rebecca, I see your comment here. Can you clarify what you're asking in terms of how many days apart?
Yeah. Do you mind if I talk instead of
No, I hope you
text?
will. No,
okay.
Go for it.
So that happened here with us at work. We had a positive antigen, and I tested the employee 3 days later with PCR. It came back absolutely negative. She had absolutely no contact with a positive COVID person. She had not gone to the grocery store. She hadn't been anywhere. She didn't live with anybody. I did contact the VDH with my person that I speak with there. She still had to isolate, and we still had to count that as a positive case.
You said that she had a negative PCR to begin with?
She had a positive antigen and then a negative PCR. It was about 3 days later. So if we're going to, from what my understanding is, you have to make sure that that PCR is done immediately with that negative antigen. And that's what my my comment was to make sure that everybody understands that you can't wait days later to rule out a negative antigen test.
Yes, thank you. That's an excellent point. The PCR test, if you're going to do that's a great point. If you're going to do a confirmatory PCR, that needs to be done right away. Okay, preferably we would like to have that PCR collected within 24 hours. Okay, because if you and the thing is, if you collect it too many days later, then if you read if you look at the document that I put the link to, it'll go into more detail, because if you collect the PCR too many days later, then essentially you're giving time for another exposure to happen.
Thank you, Rebecca. And I know we're out of time, but 2 quick questions came in, Doctor. First, when we test staff using the antigen machine, are you saying there needs to be a doctor's order for us to test the staff member? And can this be from our medical director, even though he is not the staff member's physician?
The answer to the first question is it doesn't have to be a doctor's order. It can be anybody with prescriptive authority. So that could be a doctor, that could be a nurse practitioner, that could be a PA, but it has to be an order from somebody who can write prescriptions. The second thing, can it be from the medical director, even though he is not the staff member's physician? Sure.
Okay.
Yeah.
And then the second,
then that person, owns the test result.
Okay. And then for the Abbott Binax Now cards, how are facilities documenting results, since the result shows as 1 or 2 lines on the card and there is no printout?
Yeah, what Abbott has is Abbott has an app. It's called Navica. It's N as in Nancy, A, V as in Victor, I, C as in cat, A. So it's the Navica app. And this is what Abbott used, and this is a electronic system where where results can be entered. And this is something, when you do the Binax Now training, they talk about the Navica system in terms of how do you use it, how do you set it up. So that's a great question, and that's the way that Abbott does it.
Perfect. Well, we are 2 minutes past the hour. Sorry for keeping everybody late, but thank you so much, Dr. Roshheim, for being on our call today. And Dana has put the link to the Navica app in the chat box. And Karen Riley just posted, our medical director gave us a blanket order for staff tests. So that is helpful.
That's a perfectly acceptable way to go.
Perfect. Well, thank you all thank you, Sarah. Thank you, Doctor, for being on our call today, and for all of our members' participation. And have a great rest of the week. And remember, your LeadingAge Virginia team is here for whatever you need. So thanks so much.